Welcome to the second part of the video, the 5 things you need to know if the medical team in intensive care wants to limit treatment, wants to withdraw treatment or life support, or wants to issue an NFR or not for resuscitation order for your critically ill loved one in intensive care. So we continue with the second point. The second point is there are massive moral and ethical implications and challenges involved in treatment limitations, withdrawal of treatment and NFR. And those situations are very rarely clear-cut, nor are they black and white. As I have mentioned before in this video, as well as in other reports and videos of Intensive Care Hotline.com's ebook and video series, intensive care is very rarely black and white, and there are a lot of grey areas, and there are lots of people with different views and different opinions. The important thing is that everybody's views and opinions need to be considered, and people need to compromise and make mutually agreeable decisions that are in the best interest for a critically ill patient. But what exactly are decisions that are in the best interest for a critically ill patient in intensive care? What exactly are those massive moral and ethical implications and challenges that I am talking about? More importantly, what do you need to know when it comes to issues such as treatment limitations, withdrawal of treatment and NFR? I'll give you more real-world examples again, so that you understand and you also get perspective. Let's look at an example. A previously fit and healthy 90-year-old gentleman gets admitted to intensive care after open heart surgery. The gentleman was a planned admission and he had been in intensive care for only 2 days before discharge to the ward. Everything went smoothly and he got out of bed on day 1 after surgery and is now going to the ward. Another example is a 60-year-old man had a tragic accident with severe head injuries and he is now dying. The intensive care team wants to withdraw treatment in a few hours and let the patient pass away. The family wants to wait another 24 to 48 hours as they are waiting for the patient's brother to come from overseas, and they want to make sure that he's not going to pass away without his brother being there. Another example is an 85-year-old lady has had a severe heart attack with the consequences of acute kidney failure. If the intensive care team is not commencing hemodialysis, which basically is the kidney machine, the 85-year-old lady is likely to accumulate toxins in her body that will eventually kill her. The lady was dependent on other people before the heart attack but had a reasonable quality of life. The 85-year-old lady required ventilation and the intensive care team suggests to the family to take her off the ventilator but is not planning to put her back on a ventilator should she deteriorate, which would be very likely without the kidney machine. The intensive care team therefore wants to clearly document treatment limitations and NFR and let nature take its course. The family does want to continue treatment, including ventilation and the dialysis or the kidney machine. The family is optimistic and don't want to let their mother deteriorate. The family believes that their mother will recover and that their mother was happy with her limited quality of life before ICU admission. Another example is a young 22-year-old cyclist has been admitted to intensive care after a car crashed into him. He sustained life-threatening head injuries, multiple severe rib fractures and a pelvis fracture. After many weeks in intensive care with maximization of treatment, the fractures have been fixed and he's not waking up due to his severe head injuries. He is stable otherwise. The intensive care team wants to transfer him to the ward as he doesn't require intensive care anymore. The intensive care team also wants to document a one-way discharge, meaning that a transfer back to intensive care should he deteriorate is excluded. The intensive care team further suggests to have a documented NFR form, as the intensive care team thinks the 22-year-old young man will not have any quality of life. The intensive care team also thinks that therefore NFR, or the not for resuscitation order, and not coming back to intensive care is in the young man's quote-unquote best interest. The family of the young man is appalled by the intensive care team's approach and does not agree to a one-way discharge, nor do they agree to NFR or not for resuscitation. So let's look at the commonalities in this example despite the differences. You might have seen that some of the examples I have given to you don't seem to have much in common at first. The thing they do have in common, however, is that people could argue about the allocation of resources. You can also see that things are not black and white, and that there are many grey areas, if anything. Why would a 90-year-old man need open heart surgery? Who in their right mind would not wait for family to come to a dying family member if that's what they want? Why is the intensive care team so adamant in withdrawing treatment on an 85-year-old lady? And last but not least, why would you want to limit treatment on a 22-year-old with a head injury when everybody knows that head injuries take a long time to recover? I'm not trying to put too much judgment on each individual case. However, I see and I have seen those or other similar cases over and over again with the knowledge and the insights of the moving parts in the background in an intensive care unit. I also know and understand therefore where intensive care units stand and come from. But this is where your and your family's negotiation skills, strategies and tactics come in. Your job is to estimate the situation from your perspective, whereas the intensive care team will argue from a standpoint of quote-unquote evidence-based practice or best practice, whereas you will more likely argue from an emotional and gut standpoint. Of course, some of the intensive care staff are emotional too, but they might be more detached. Don't underestimate your ability to use your judgment and your discrimination in the situation of what really is in the best interest for your critically ill loved one. Your judgment might be more based on your gut feelings and knowing your critically ill loved one well enough to understand his or her strengths and weaknesses, and therefore also understand how he or she deals with adversity. As I have said in number 1, and I can't emphasize this enough, that every intensive care unit has documented policies, procedures and guidelines regarding limitation of treatment, withdrawal of treatment and NFR that they have an obligation to follow and adhere to. If you ask for those documents, and don't be shy to do so, you will find that there is always documentation that the family needs to agree and give written consent to limitation of treatment, withdrawal of treatment and NFR. They are massive steps to take, and you certainly don't want to have your 22-year-old son or daughter leave intensive care with a treatment limitation order. Just by taking a stand and by asking the right questions, you automatically exercise more control, power and influence. And once again, just like I said before, you will stand out from other families in intensive care just by you asking the right questions and having an awareness of the moving parts in the background that most other families in intensive care are totally unaware of. Most families in intensive care are just suffering silently without taking any initiative because they are overwhelmed and often paralyzed by the stress they are going through. Be different and keep asking lots of questions, keep asking the right questions, and you'll do yourself and your critically ill loved one a big favor, and you'll shift dynamics immediately. What might be the most frustrating part for you is the fact that the intensive care team most always will argue their case in what might be, quote-unquote, in the best interest for your critically ill loved one. But what exactly does that mean? It means that the intensive care team thinks, from a medical standpoint that this course of action would be, quote-unquote, in the best interest for your critically ill loved one. It doesn't take into consideration how you feel and what your gut feeling is telling you about the situation, and what your gut feeling is telling you about your critically ill loved one in this situation. Also, keep in mind that the intensive care team argues strictly from an intensive care point of view, and as I have mentioned in our other ebooks and videos, intensive care professionals often have no idea what is happening to patients outside of intensive care, and they most of the time don't know what happens to a patient's recovery once they have left intensive care. Their arguing is often based on an intensive care mindset and paradigm, and often leaves other points and opinions out of the equation. Just consider the following. Is it ethically and morally right to have an opinion what is, quote-unquote, in the best interest of someone that's not your family member or close friend? Some people, including intensive care staff, might have an opinion what is in the best interest of someone. However, nobody knows your loved one as well as you do, and therefore you should have a strong point of view and a strong opinion of what you think is best for your critically ill loved one, and you should stand up for it. Let's move on to point number 3. How important are intensive care units' policies, procedures and guidelines around limitation of treatment, withdrawal of treatment and NFR or not for resuscitation, and what do you need to know about it? As I mentioned before, every intensive care unit has written policies, procedures and guidelines around the decision-making process regarding treatment limitations, withdrawal of treatment and NFR or not for resuscitation. Those policies, procedures and guidelines vary from intensive care unit to intensive care unit, but in essence entail similar steps in the process. The decision-making process is usually outlined and justified by what is currently perceived best medical practice or evidence-based practice, and also what is the perceived, quote-unquote, best interest for a critically ill patient from a medical point of view. There can be, of course, deviations and different interpretations from the written policies, procedures and guidelines, and they are often dependent on the individual's moral and ethical values of the nursing and the medical staff, and also the general culture and the general atmosphere in an intensive care unit. Also, positive versus negative culture, or open-minded versus closed-minded culture. Now, the bottom line is that treatment limitations, withdrawal of treatment and NFR cannot be issued without your consent. Most policies, procedures and guidelines around those issues also state that treatment limitations, withdrawal of treatment and NFR cannot be issued without the acceptance and the approval of the critically ill patient's family or next of kin. The policies, procedures and guidelines are often not written to look at ethical and moral dilemmas that inevitably come with the highly emotionally charged territory. It doesn't talk about how a family might feel when presented with the stark realities of their critically ill loved one in intensive care. It's therefore absolutely critical that you ask for the documents about treatment limitations, about withdrawal of treatment and NFR, and that you familiarize yourself with the aspects and the steps around the process You also need to know about your rights around the process. As I have said many times before, if you do just that, if you are standing your ground and you stand out from the crowd just by simply asking the right questions, you immediately exercise more control, influence and power, because you and your family will not give up lightly and you are not taking no for an answer. I would never go as far and say that health professionals in intensive care are emotionally detached from issuing treatment limitations, withdrawals of treatment and issuing NFR forms. I am, however, very aware of the competing interests, competing demands, the moving parts in the background, and also of the intensive care team's often highly academic view of the clinical issues at hand, which often leaves a discussion about moral and ethical dilemmas out of the equation. This often highly and purely academic point of view of the medical staff, and sometimes the nursing staff as well, leaves often no room for your gut feeling. It also leaves little room for you knowing your critically ill loved one best, because you know your critically ill loved one well enough and you understand how he or she can deal with adversity. Unless you are persistent and vocal about your beliefs in your critically ill loved one's fight to fight against adversity and against the odds, some of the members of the intensive care team might only look at the medical facts. So your job therefore is to bring up your reasoning and to fight for your beliefs. The problem is the intensive care team has their positioning worked out well in advance, and you need to work your positioning out as well. Because there are so many competing interests in the background, the intensive care team has probably made up their mind already of how to position the clinical facts they are going to tell you. They have also made up their mind about how to position themselves and their management plan for your critically ill loved one. They have also worked out how to document in your critically ill loved one's medical and nursing notes their withdrawal or limitation of treatment plan, including NFR. Even though this actually may violate hospital or intensive care policies, procedures and guidelines without your knowledge. It is extremely important for you to know that policies, procedures and guidelines are just that. They are policies, procedures and guidelines. They are written documents. They are not more and not less. Keep that in mind and make your judgments accordingly. You need to know that health professionals in intensive care, and doctors in particular, often have a highly academic view of things. For them it's often black and white, whereas in your reality it's probably not black and white. It's often a grey zone. Keep that in mind at all times and position yourself strongly and accordingly. Talk about your concerns, your fears and your frustrations. Be persistent and be vocal in demanding fairness and transparency in the process. Let's move on to number 4. How to find your unique voice in this process. I see and I have seen a lot of families struggling to find their voice in this process. They are struggling to find their voice because they are so overwhelmed, frustrated, fearful, vulnerable, and they feel challenged. Moreover, because time is often their enemy, they lack the time to make any independent investigations or find useful information in what to do. They also lack the time to digest and understand what is really happening. They also feel like they haven't really been heard in the cascade of events and decisions. They also feel like they lack the time to verbalize their feelings and therefore make their views and concerns heard about their critically ill loved one's situation. Now, one of the most important things is that you don't let fear, overwhelm and frustration stop you from speaking up and taking control. As you can see, I can write and speak about this topic for a long time to come, because of the pain that I'm going through each time I'm confronted with end-of-life issues, and also because of the pain I have been going through when dealing with death within my own family. For you, it might be different. Unless you have been in a similar situation in the past, you may have no problem finding your voice in this process. You may know exactly what you want and you can verbalize it. Congratulations if you have found your voice already. You are well on your way to master the situation and the challenges. But if you have never been in a situation like this before, you are of course struggling to either have a voice or finding your voice. You and your family might still be overwhelmed and feel paralyzed by the sheer frustration, the stress and the pain of the situation, and now you are confronted with the next issue on a long list of issues. You are not taking this issue lightly, but you don't know where to start. And usually, time is your enemy. The situation demands a quick response from you. The challenge is that the intensive care team is often positioned to make a decision for you, for your family, and for your critically ill loved one. They appear to be in control and they have perceived power. The challenge also is that you are not positioned to make a clear-cut decision because there are often too many unknowns, and there are also unknowns that you don't even know are unknowns. In fact, you are facing far too many unknowns and complexities to deal with. Time is your enemy because the situation doesn't give you a great deal of time. It all depends, of course, but especially in end-of-life situations, you may only have 24 to 48 hours left. So, how do you find your voice in such a challenging and difficult situation? Well, the first step, of course, is to find as much information as possible about your critically ill loved one's situation. You should be able to get a great deal of information just from our free resources on our intensivecarehotline.com website. Next, if you are not entirely clear on where you stand in terms of management of your critically ill loved one's care and his or her end-of-life care, try and buy some time. Hopefully, you are in a position where you can have another 24 to 48 hours to think about your situation by asking the intensive care team to keep your critically ill loved one alive. If you are still unsure, take your personal values and beliefs, scrutinize them, and base your decisions on your personal values and beliefs. I also can't stress enough that you should listen to your gut feeling. Your gut never lies. Next, speak from your heart and don't let the clinical facts or the academic view of the intensive care team stop you from having your emotions speak. Your emotions are a healthy sign that you are positively engaged in this challenging situation. Don't think that just because you are dealing with specialists in intensive care that they know it all. They certainly know a great deal about intensive care and their craft within that environment, but once again, that mustn't stop you from giving your input into the situation. Sometimes, just by you and your family giving input and by making sure you are influencing decision making, you might be in a position where you are buying time, and sometimes by gaining extra time, your critically ill loved one may show signs of either improvement or deterioration. Especially in a perceived end-of-life situation, this can be extremely valuable time to have. Rather than rushing into a decision that you don't feel comfortable with, by buying time, the universe might give you the hints that you have been waiting for of which direction to take. Also, don't underestimate the level of power, control and influence you are exercising just by positioning yourself strongly, by not giving up and by not taking no for an answer. The intensive care team has a certain view and certain perceptions about you and your family. Those views and perceptions are often based on first impressions and they are also based on the intensive care team's perceptions of how you are dealing with this situation and how much they think you know and understand about the situation. Let me say this again. The intensive care team's views and perceptions are based on how they think you are dealing with this situation and how much they think you know and understand about the situation. That means it's not based on reality. It's based on perception. So, therefore, if you change the intensive care team's perception about you and the level of influence you have and exercise, you automatically shift dynamics in your favor once again. I have seen too many situations where the intensive care team had all the power because families didn't think and didn't believe they could influence a situation. The minute that you think you can influence a situation, you probably will, and you probably can. The minute you think that you can't influence decision making, you probably can't. You therefore need to be able to control the three most important things in this situation, which are your thoughts, your brain, and your beliefs. Do just that and you are well on your way to mastering this situation. Let's move on to the fifth and the last point. Your critically ill loved one's age is not as important as you think it is in the decision-making process. As you have seen in the previous points in this article, I have given you a few real-world examples about critically ill patients in intensive care, and I have given you examples about the intensive care team's positioning, your and your family's positioning, how you can influence decision making, how you can influence reality and perceptions in your favor. Furthermore, as you have seen in the real-world examples that I gave you earlier, I have always included a critically ill patient's age. I have given you the critically ill patient's age so that you can see that a critically ill patient's age in intensive care doesn't necessarily impact on the decision of the intensive care team to either go full throttle on a patient's treatment or, on the other hand, limit a patient's treatment. A lot of those decisions from an intensive care point of view are based on their perceptions of the critically ill patient's future, irrespective of the patient's age. Contrasting treatment options might actually go hand in hand with different age groups. As outlined in one of our examples before, a previously fit and healthy 90-year-old would be having cardiac surgery despite their age, as long as there is perceived quality of life. A 22-year-old with severe head injuries might end up with treatment limitations if the perception is that there may be no perceived quality of life. The list could go on, but those two contrasting examples should give you an idea of where your critically ill loved one might fit in. And more importantly, you need to understand that it's only based on the intensive care team's perception. The intensive care team, once again, lives and breathes intensive care, and generally speaking, they have no idea how a patient might fare outside of intensive care. The intensive care team are the specialists for intensive care, and they are not the specialists for what's happening after or outside of intensive care. By having that knowledge, you can position yourself accordingly during negotiations and meetings. I can give you another real-world example so that you can see how age is not a determining factor on the decision-making process and what to do about it. A critically ill 41-year-old lady with 2 young children has been admitted to intensive care after having been diagnosed with breast cancer 2 years ago. Unfortunately, the cancer has spread widely into her lymph nodes. The 41-year-old lady is now rapidly approaching her end of life, and she is expected to pass away within the next 2 to 4 weeks. The 41-year-old lady is weak but fully conscious in intensive care, where she is receiving intermittent, non-invasive BiPAP ventilation and inotropic therapy for her difficulties that she has with her breathing, and she is receiving the inotropic therapy for her low blood pressure. The intensive care team has already made up their mind in where to go, or even more importantly, where not to go with the treatment of this 41-year-old critically ill old lady due to the limited life expectancy. Now, I'll give you a hint here. Is the intensive care team breaching intensive care policies and procedures? Now, the intensive care team has already come to the conclusion that invasive ventilation and intubation and unlimited inotropic support, which is for low blood pressure, and CPR, which is cardiopulmonary resuscitation, in case the 41-year-old lady's heart would stop beating, would not be quote-unquote appropriate for her. The intensive care team have already documented those treatment limitations and NFR in the medical and nursing notes of this critically ill patient without informing the patient and or the patient's family. Written patient or family consent has not been given for those limitations of treatment, and therefore hospital policies and procedures have been breached. What's even worse in this example is that basic human rights have been breached. The intensive care team thinks that these decisions are quote-unquote in the best interest of the 41-year-old lady. Discussions about treatment limitations and NFR are hard, difficult and confrontational discussions to have, especially when a critically ill patient in intensive care is awake and fully conscious. The reality is that the intensive care team is often avoiding difficult and challenging discussions with the patient and their family. The reality also often shows that in order to not have those difficult and confrontational discussions, that it's easier to just document those treatment limitations order without actually talking to the people affected most by it, which is the critically ill patient and their family. Once again, the common view of the intensive care team is that, quote-unquote, we know what's in the best interest of a critically ill patient in intensive care. Furthermore, it would be difficult, even for the most experienced doctor or nurse, to have confrontational discussions with an awake and fully conscious patient about their end of life. It's therefore often the easy way out to just document and inform the intensive care team and not the patient and their family. I am not disputing the fact that in our real-world example, the 41-year-old lady is approaching her end of life. I am, however, strongly disputing the fact that her and her family have not been informed about the clinical decisions made by the intensive care team. Therefore, hospital and intensive care policies and procedures and basic human rights have been breached. An illegal process has been started. Also, by making those decisions, it might limit the patient's time spent with her husband and their young children. Even a few more days can be very important in such a difficult situation. You see, if in our example we would be talking about your spouse, you would want to spend as much time with her or him as possible, and more importantly, you would want to know what decisions might have already been made from a clinical perspective without you and your critically ill loved one being involved in the decision-making process. Once again, transparency and openness in the process has been totally lacking. I have given you this example because people often think or have an impression that age is more relevant in the decision-making process. Our real-world examples have also shown you that you should questioning everything and that you shouldn't assume anything. Just be open-minded and keep asking questions. Keep asking for documentation in your critically ill loved one's notes, especially if you are questioning the intensive care team's approach. If you keep doing that, you'll find out if the intensive care team has anything to hide or not. you will see how open and transparent they will be in the process around treatment limitations or NFR. You will also get a feel for the culture within the intensive care unit. I really hope that this video has served you well, and I hope that you have gained even more insight of how you can effectively deal with your fears, frustrations, your struggles, your vulnerability, and how you can turn the situation around so that you feel powerful, in control, influential, and so that you are mentally well positioned and mentally strong to deal with this challenging situation. Hopefully, I was able to elevate your thinking and also to lift your spirits. I also hope that I will see you in one of our other ebooks and videos so that you can find even more strength, more power, more energy, greater influence, and also hope in your challenging journey through the intensive care landscape. For more information on a variety of topics within intensive care, check out more of our reports and ebooks, and also read our blog for more tips and strategies, and check out our Your Questions Answered section. You can find the links on our blog or in the ebook of this video. You can also send me an email to support@intensivecarehotline.com if you have more questions. Thank you so much for watching this video, and I'll see you again in one of our other videos. This is Patrick Hutzel from intensivecarehotline.com. Thank you.